Um, Hello and welcome everyone, and welcome to spring. Thank you all for coming tonight to webinar 5 in the Obesity Management series, brought to you by obesity doctors in the ACT and Capital Health Network. Tonight's topic is post-bariatric surgery, long-term care and complications. And the previous 4 webinars in the obesity series are on the Capital Health Network YouTube page, and this webinar will be uploaded to the YouTube page shortly. So if you want to rewatch it, you can. I am Dr. Leonie Harcourt, a GP advisor at the Capital Health Network. And also with me tonight are Dr. Louise Brightman, Dr. Deborah Inman, Dr. Carol Huang, and Dr. Richard Singer, and of course, Kunal Mohiti from the Capital Health Network. So first, we would like to acknowledge the traditional custodians of the land we are meeting on. We acknowledge and respect their continuing culture and the contribution they make to the life of this city and this region. And we pay our respects to their elders, past, present, and emerging. We also acknowledge and welcome other Aboriginal Torres Strait Islander people who may be attending tonight's event. So as usual, all participants have been muted. And if you have any questions, put them in the Q&A box, not the chat box on the Zoom panel. And we're going to have 2 question and answer sessions. So we're going to have one at the end of Dr. Brightman's presentation and then one at the end of Dr. Inman's presentation. And in regards to CPD, Capital Health Network will provide a certificate of attendance after the event. And we're also sending out an evaluation survey. So please feel free to self-report. So we're not going to do it for you, but if you'd like to self-report 1.5 hours of educational activities to your CPD home. Our first presenter tonight is Dr. Louise Brightman. Louise is a psychiatrist working at the Canberra Obesity Management Service. She has a background in public health and chronic disease management and has spent the past several years working in remote Central Australia. Louise has SCOPE certification through the World Obesity Federation. She also has postgraduate qualifications in forensic mental health. Louise will be talking about post-bariatric surgery mental health concerns. And yeah, please put your questions in the Q&A box, and we'll have a Q&A session after Louise's talk and also after Deborah's talk. So thank you very much, Louise. Louise, you're on mute still, so could you start again? Thanks.
Okay, hopefully everyone can hear me now. Sorry about that.
Yeah, we're good. Thanks.
Okay. Well, thanks for inviting me back and giving me the opportunity to present again. So today I'm going to be talking about some of the mental health issues that can arise in the post-bariatric setting. Learning objectives include identifying risk factors for mental health deterioration post-bariatric surgery, managing new or recurring mental disorders following bariatric surgery, and considerations regarding psychotropic prescribing in the bariatric surgery context. Just a brief overview. So I'm going to summarize some of the things that we've touched on in some of the previous sessions. Again, talking about those risk factors, identifying new and recurring mental disorders, and psychotropic prescribing, including the pharmacokinetics and some of the issues that might arise in the post-bariatric setting. And I'm happy to receive questions either now, or if people think of questions later, they can email me. So just to summarize, obesity and mental health, it's a complex interplay of a range of factors, including genetics, environment, iatrogenic. So we know that medications can be a big cause of weight gain in patients who already have mental illness. Motivation and cognition play a role. And from a more medical perspective, we know that there's HPA axis dysregulation, which is then linked with metabolic derangement, chronic inflammatory states, and mood dysregulation. And that seems to sort of they all seem to feed into each other. We know that the greater the severity of mental illness, the greater the risk of having a higher BMI. So we know obesity is defined as a BMI greater than 30, but we often see people with BMIs of 60 or 70 or above. We also know that with increased BMI and a severe mental illness, there is a reduced life expectancy and an increased number of medical-related comorbidities. And if we think about the mental health comorbidities that are associated with obesity, the most common ones are mood and anxiety disorders, eating disorders, and substance use disorders. Psychotic illness is also features, and again, that seems to be more in relation to some of that antipsychotic medication use, and also developmental or early life trauma can have a big role in developing obesity later. So after a patient has had undergone bariatric surgery, regardless of the type of bariatric surgery, they are at risk of a deterioration in their mental state. So there are some general surgical and medical complications that can increase the risk of deterioration. So we know that people with a brittle mental illness, like a very brittle bipolar disorder, people with psychotic illness, or psychotic depressions, they can really be at risk of not reacting well to anaesthetic. The medications that might be added to their complex regimens during hospital that polypharmacy can also lead to mental health deterioration. And so can things like pain and sleep disruption in that peri-surgical space. Also, any reduction or cessation of mental health medication, whether that's in that immediate period following surgery or in the weeks, months after surgery, that can lead to a deterioration in mental health, and that can lead to a relapse in some cases or the onset of new mental health conditions. Psychosocial factors also play a role, and this is more in keeping with from an individual perspective. Sometimes people have unrealistic expectations about their how much weight they can lose, and we've spoken about that in previous sessions. Or some people might lose weight but then not be aesthetically or pleased with the aesthetics of that, because they might then require some plastic surgery for excess skin, for example. So people might have very high expectations going into the surgery, and when that's not met, that can actually impact on mental state. Lack of support is common, so not just in terms of assertive follow-up from a mental health professional perspective, but also the social support. So some people might have they might be the breadwinner or the sole carer for their families, and they don't have a lot of people supporting them in terms of their needs. There can also be pressure from other people for people to look a certain way or to lose a certain amount of weight. And there are also cases where intimate partners might actually not want the patient to lose weight too. So people are trying to manage all these new emotions in addition to the medical changes. External weight stigma, so from society in general, but also among the health profession, can also be lead to deterioration in mental health. And also internalized weight stigma is really important. And that's where patients themselves might view themselves as being unattractive, not having a very good body image, having a low self-worth, even after surgery. The other thing is that people might have some improved physical or medical, or they might get some improvements in their physical or medical health, but their psychiatric symptoms may remain unchanged. So some people, and again, I think I've mentioned this before, put a lot of hope in weight loss and that will be the cure. That's going to make them happy. That's going to solve a lot of their social problems or their feelings about themselves. And that doesn't always happen. And so that can be really disappointing and lead to a relapse of depression, for example. So when we talk about mental disorders in the post-surgical space, they could either be new onset disorders or a relapse of an existing disorder. There could also be an additional disorder added to their already existing mental illness. So with a new onset disorder, they would have to meet the criteria for a new disorder as per our diagnostic criteria. Psychosocial factors are at play there, and also family history. So particularly for disorders like bipolar disorder and schizophrenia, there might already be a strong family history and the patient has a genetic predisposition to developing these disorders. So any insult on the mind and body, whether it's surgical or otherwise, can actually precipitate the development of the illness. The other thing to think about, especially in the GP setting, is whether or not this is a new disorder or whether it was actually pre-existing but not diagnosed. And that could be because patients didn't perceive it as a problem at the time, or there was shame about seeking help for that certain condition. So, for example, perhaps an eating disorder that wasn't picked up prior to the surgery. In terms of relapse, that usually occurs in the context of those stresses that I mentioned before, but also pharmacokinetic changes where they're not absorbing the medication properly, so they're at increased risk of not having their mental illness adequately treated. And in terms of managing these sorts of problems as they arise, it's important to get some diagnostic clarification, to do a risk assessment, which I know everyone already does, and then consider whether medication is necessary. Psychological support is always useful, but again, it depends on accessibility and cost, and then considering whether or not to refer to specialist services. So that might not just mental health services or private psychiatry and psychologists, but also considering whether or not someone might need a referral to the alcohol and drug service or the eating disorders program. So just a few statistics about bariatric surgery patients in general. They have a higher prevalence of comorbid mental illness. So if we use depression as an example, depression as a comorbidity in patients with obesity, not necessarily those having bariatric surgery, the prevalence is about 30%. So you can see those who actually progress to surgery have a 40% chance of having an Axis 1 diagnosis. And for people that are not familiar with Axis 1, it's an older terminology that was used in the psychiatric space to sort of separate different disorders. So Axis 1s are traditionally the mood disorders, schizophrenia, whereas Axis 2 include more of the complex things like personality disorders. So you can argue that probably there's a higher rate of comorbid mental illness across the spectrum or range of psychiatric illnesses in those having bariatric surgery. There was a large US study published recently, and they looked at people who underwent bariatric surgery. I think there were more than 2,000 people in the sample, and up to 35% were prescribed at least one antidepressant prior to surgery. I'll talk about that paper in a little more detail in a minute, but I guess something to just keep in mind is that as obesity becomes a bigger problem, there's going to be a more demand for bariatric surgery for people. So people who may not have been considered suitable or couldn't access bariatric surgery in the past, they are going to be presenting, and rightly so, may require bariatric surgery. So we're expecting to see people with more severe mood disorders and psychotic disorders and generally more complex mental health presentations in that bariatric setting. The evidence shows that the weight loss outcomes are poorer if a patient has a mental health relapse following surgery. So this is the US study that I mentioned just before, and I just wanted to draw people's attention to the antidepressant medication use. So you can see prior to surgery, 35% of patients were prescribed at least one antidepressant, but then 6 months later, you can see that that drops to 24. And then over the course of 3 years, it goes up slightly again, but not to the rates prior to the actual surgery. To me, I looked at this and thought, look, that might be a little bit too optimistic, stopping an antidepressant so soon after surgery. And it's something to keep in mind. Again, going back to that idea that a patient might feel had that initial sort of euphoria that my life is better now, my mood is under control, everything's fine because I've had the surgery and I'm losing weight. So I would just err on the side of caution in terms of being too hasty to cease medications too soon. The other interesting thing there is that you can see the hospitalization for depression at baseline and years 1 and 2. At baseline and year 1 were similar, but then you can see at 3 years it's actually increased. So eating disorders in the post-bariatric setting are very common, but detecting them can be really tricky because a lot of the post-surgical changes that occur can actually mimic an eating disorder. So there's some examples here for looking at restrictive bariatric surgery, like a sleeve gastrectomy. Because the volume of the stomach is smaller, there's going to be a natural reduction in the food intake. And if people are eating too much or too quickly, it might lead to vomiting. And so if you think about in the context of an eating disorder, that could be mistaken as a restrictive or purging type of anorexia nervosa, or a bulimia nervosa with some compensatory vomiting. Similarly, with the gastric bypass, which is like a malabsorptive type procedure, patients might present with diarrhea, for example. So then you then have to ask the question, well, is this a side effect of or an adjustment following surgery, or is this an eating disorder? So again, anorexia nervosa has a purging subtype, which includes vomiting, the use of laxatives, which could be explained with diarrhea, and similarly with bulimia nervosa. The other thing to consider is that eating disorders in the post-bariatric setting may not present or meet the diagnostic criteria for what we would think of as a traditional eating disorder. So with people can develop anorexia nervosa, so they might meet the restrictive criteria in terms of food reduction, but that's in the absence of a low body weight or a low BMI. So if we think about the diagnostic criteria for anorexia nervosa, as it stands, a patient who may have had a BMI of 70 and has reduced it to 60 or 50 through inappropriate restriction of food or compensatory behaviours, you would argue that they have an atypical type of anorexia, but those severity specifiers, whether it's mild, moderate, severe, or extreme, they don't apply, because you can see here that it requires the BMI to be quite low or very low. So in these cases, it's always useful to check to see whether there's an intense fear of gaining weight or extreme behaviours to avoid weight gain, and whether the patient has a disturbed body image or body shape. But in saying this, we know that these things can also happen in patients who have had bariatric surgery and don't have an eating disorder. So some people might just be very conscientious and following the dietary guidelines to the T all the time in terms of preparing portion sizes, calorie counting, and having a fear about gaining weight. So that's just something to keep in mind. It's really hard to detect and unpack. Binge eating disorder. So that's the most common eating disorder generally, and it's a relatively new classification of an eating disorder. It only was included in the DSM-5 back in 2013. So binge eating disorder is usually defined by eating a large amount of food in a discrete short period of time. So if someone in the post-bariatric setting had a binge eating disorder, how they might present to you in the GP setting is that they might have prolonged grazing, so smaller amounts of food, but throughout the course of the day. But again, this means that they might not meet the traditional criteria for a binge eating disorder. But some things to keep an eye out for is whether the person feels as though there is a lack of control. That's one of the criteria for a binge eating disorder, and that persists even in the context of that prolonged grazing. Also, patients will continue to feel a lot of distress, guilt, and disgusted with oneself if they're binging or grazing in the context of a previous binge eating disorder. I put disgusted in quotation marks there because that's the way it's defined in the DSM, and it's quite a harsh word, and I don't like asking it sometimes, but patients really do identify with that sort of disgusted sense of self. So it just shows how hard it is for people with these sorts of eating disorders. Feeling uncomfortably full is not a good indicator of whether someone has a binge eating disorder in the post-bariatric space, because we know that particularly with a sleeve gastrectomy, you've got a reduction in that stomach volume, which means the stomach fills sooner, and those pressure receptors at the top of the stomach are triggered to send those full signals to the brain. So that's not the best way to determine what's happening. And again, the severity specifiers are hard to apply in the post-bariatric space because they're based on the amount of discrete episodes of binging per day. And it's really hard to quantify grazing. Hopefully we're okay with time. So with alcohol use disorder, there's evidence to show that there is a small but increased risk of people developing a new onset alcohol use disorder following bariatric surgery. The risk is highest with the gastric bypass procedures, and they think that this is related to increased alcohol absorption, which then increases your blood alcohol concentrations, and the prolonged elimination, so the beneficial, the nice effects that we get from alcohol. With sleeve gastrectomy, which is what our service, the OMS, is funded for, it's less clear, and there's no evidence at the moment that gastric banding leads to increased risk of alcohol use disorder. But it's not clear if there's just not enough research there as opposed to being a true difference. Again, research shows that there is an increase in alcohol consumption in the second year following bariatric surgery, and 8% of post-bariatric patients develop a new alcohol disorder as opposed to one having one existing and then sort of re-emerging in the post-bariatric space. I've included some risk factors here, which I think are really important. So male, smoking status, a younger age at the time of the surgery, a family history of any substance use, but particularly alcohol. And if there's more than one family member with a substance use disorder, that places that person at increased risk. If people were using alcohol prior to surgery or have had the surgery and started drinking regularly, that can also increase people's risk of then developing a full alcohol use disorder. A poor sense of self or a poor sense of social belonging and complex mental health needs can also predispose to the development of an alcohol use disorder. Pre-surgery food addiction is also a risk. I don't use that term very often. I'm not sure about you, Deb, Carol, and Richard. But there are screening tools to screen for food addiction, but that's not something that we commonly do. So other addictive disorders can also emerge. They say that addictive behaviours are more likely to increase post-surgery, which suggests that they might have been present in the past but haven't actually caused a problem until then. And the researchers noted that it's usually composite addictive behaviours, so people combining alcohol use, cigarette smoking, other drug use, as well as non-substance addiction, so shopping, internet use, and gambling. These also tend to increase in the second year following bariatric surgery. And then it sort of leads into this idea or concept of addiction transfer. So a shift from non-hungry eating or comfort emotional eating to manage people's emotions. They then, if they can't do that anymore because of the bariatric surgery and they're physically limited, then they might transfer the need to self-soothe in another way. So that could be alcohol or those other addictive behaviours up there. There's not a lot of data about addiction transfer at the moment, but they do say that there's possibly a prevalence of around 3% for a new addiction disorder or addictive disorder developing. So some of this information was on in the last presentation I gave, but I'll just touch on it briefly again. So we know that following bariatric surgery, there are changes in terms of the pharmacokinetics. So absorption can change secondary to a change in gastric emptying rate. So if someone's on a slow release medication, if it's possible or if it exists, it's helpful to change people to an immediate release formulation in the lead up to surgery. But this again depends on the type of surgery. For us at the OMS, we do the sleeve gastrectomy, and it doesn't seem that the sleeve gastrectomy causes too much trouble in terms of absorption, but it's still something to consider and it can still occur. If people have a very serious bipolar disorder or a psychosis and they're on oral antipsychotic medications, it's worth having a discussion with patients as to whether or not they would consider having a depot. And I mean this in the voluntary sense, so not under the Mental Health Act, and having that conversation about the risks and benefits and how having the depot medication administered may protect them from having a relapse and then having those extended admissions and rehab. Because we know that each time someone does have a relapse, and the severity of the mental health relapse means that it takes longer to recover and that their outcomes are not as good moving forward. It's important to monitor medications that have a narrow therapeutic index. So lithium is a good example here, particularly in the context of a reduced stomach capacity. So that might mean that people, at first, it's going to be a challenge for them to keep up an adequate fluid intake, or they might be vomiting. So they're going to be at increased risk of dehydration. And in terms of lithium, there are protocols out there and guidance to show you what sort of, or the frequency of monitoring in the lead up to surgery, as well as immediately post and then longer term. In the lead up to surgery, patients are often required to do a very low energy diet. And so that's when we recommend that you start looking at lithium levels once a week while they're on the very low energy diet prior to surgery. So distribution changes can also occur as a result of reduced adiposity. So this has implications for lipid-soluble agents, and a lot of the psychotropic medications are lipid-soluble. Changes in metabolism and excretion, which I've mentioned before. So you can actually get, with weight loss post-surgery, you can get an improvement in renal and hepatic function, which might mean that the metabolism of those medications and excretion is enhanced, and then that might have implications in terms of dosing changes. Some things to keep in mind with some short-acting antidepressants, for example, if people aren't absorbing them properly following surgery, they can be at risk of experiencing discontinuation syndrome, which is essentially a type of withdrawal. And this graph or table here just lists a few different things that people can present with if they're not absorbing their SNRI or SSRI. And there are some similarities with a relapse of depression, for example, but if there was a relapse of the mental illness, we're talking weeks to months usually after the procedure. And I've also just included this table. So it's from the Maudsley Psychiatric Prescribing Guidelines, and it just gives us a nice overview of some things to consider in the lead up and then following bariatric surgery. And it's reference number 5 that includes those tables if anyone wanted to take a closer look at those. I hope that was helpful.
Thanks, Louise. That was very helpful. I might kick off with some questions if that's okay. So I was just wondering, you were mentioning kind of monitoring, particularly people with bipolar post-bariatric surgery. Do you think the city mental health teams and the community mental health teams are aware of the potential medication modifications they need to make, or is that something, I mean, it's obviously good if the GP and the mental health team are on top of that, but sometimes the mental health team kind of takes more control of that. So are they on top of that routinely?
Well, look, I'm not sure because it's early days in terms of equitable access for mental health patients accessing bariatric surgery. So I'm not sure how often the patients that are severe enough to be managed by a community mental health team, how many of them are actually undergoing surgery. Normally, the surgeon would provide some information about it as well and send that back to the referring doctor. The good thing about the mental health service here is that they've got a steering committee on physical health, and so the OMS as part of that has been invited to be part of that. So I think ongoing education and maybe more awareness would be a good thing. Not to say that they may not already be aware, but I don't have any direct interactions with any of those patients.
Yep. And I've just got one other question. So in terms of neurodiversity and bariatric surgery, how do people go, say, for example, with ADHD or autism post-bariatric surgery? In particular, like, for example, with ADHD and medications, a lot of them are on the long-acting stimulants, and are they still okay?
Yes, yeah. So the Maudsley guidelines, there's a bariatric section in there. So that actually addresses some of the methylphenidate and other medications for ADHD. ADHD is interesting because the medication can help so much, but if someone doesn't have it, they're not at risk of an acute relapse or crisis that would necessarily warrant a mental health admission. So, and we know that some people actually have drug holidays from their stimulants to give them a break. So the dangers of stopping the medication are not too bad. But if you think longer term and making sure that people are able to receive the benefits of that surgery, I would be more inclined to consider doing the shorter acting medications, which can be problematic for people who are at school or studying or in the workplace, because they've got to then set alarms and make sure that they're having 2 doses a day. But that would be one way to avoid people not absorbing it.
Yep. Yep.
Oh, I'm sorry. Did you want me to mention neurodiversity in terms of ADHD?
Yeah.
It's a real challenge, particularly for our service. So our service and other obesity services promote self-management, but depending on the severity of, for example, an ASD diagnosis and whether people are comfortable coming to the clinic, comfortable engaging in groups, or even just attending medical appointments one-on-one, that can be a bit of a challenge. And so that's something that we've identified as something that we might need to work on down the track if we've got the funding and support. But it is a problem.
Yep. And sorry, I just had one more question because it's me. How often do people reveal that they've got an eating disorder? So I imagine there would be a bit of a motivation not to reveal it before surgery, because they might have the perception that that will kind of put them lower down the list for surgery. And then after surgery, they still might be reluctant to reveal it. Is that an experience that you've had?
Yeah, look, as we know, people, especially if they're a higher weight, they're more likely to seek help for weight loss rather than an eating disorder, even if they do have the eating disorder. So it doesn't come to light often for years later. In our clinic, we often get new referrals, and it's sort of revealed at that time that they've got an active eating disorder or that they've had a history of an eating disorder. And so it's about trying to figure out how we can best manage those people. There's a growing body of literature as well to sort of say that people with an eating disorder shouldn't necessarily be excluded from bariatric surgery, because if they're experiencing the complications of having obesity, their health is at risk too. So how do we police that? How do we help with outcomes going forward? There are some Canadian studies that look at the recurrence of binge eating in the post-bariatric space. And there's some new predictive tools coming out that seem to sort of help us identify who's more likely to relapse or develop an eating disorder down the track. But it's still a little bit hit and miss. And to get to your point, I don't know the exact prevalence, but we're actually going to be doing a QI project to try and gather some of that data, because we recognise that eating disorders do make obesity management that little bit more complicated, and we want to try and give those patients the best chance of success and recovery as well.
Perfect. Thank you. Thank you. They were great answers. Thank you, Louise. Okay, so we'll move on to Dr. Inman now. So our second presenter is Dr. Deborah Inman. Deborah is a respiratory and sleep physician at Canberra Hospital and has been the clinical director of Obesity Management Service since 2022. Her main interest is in obesity, sleep, and post-bariatric care. So it's great that she's talking to us tonight. Deborah has SCOPE certification through the World Obesity Federation, and she would be talking about post-bariatric surgery medical considerations. Thank you very much, Deborah.
Thanks, Leonie. Can you hear me?
Yes.
Great. All right. Thanks for having me here again, and certainly don't put myself forward as an expert in this area, so learning all the time. But this is a topic that I'm trying to learn more about, and hopefully can, it's a big topic, but hopefully can give a bit of a structure and approach to it. So the learning objectives I came up with for this talk were really having an understanding of what the expected weight trajectory or outcomes following metabolic bariatric surgery are, to give us a context for a patient that can present at different time points after metabolic bariatric surgery. Develop an approach to assessing a patient presenting to you who has had prior metabolic bariatric surgery. And really, because it's such a big topic, we're not going to learn it all in one webinar, but describe how to access some information and to help manage patients post metabolic bariatric surgery. So just as an overview of the talk, a quick approach to a patient with previous metabolic bariatric surgery, brief revision about the types of surgery that are out there. What are our expectations, particularly in terms of weight reduction post-surgery? Post-operative management after metabolic bariatric surgery, and this really is a fly-through. And then just a couple of cases with some reference to the guidelines to sort of show you, I guess, how I use them. But the focus probably is on patients presenting with weight regain. So an approach to a patient with previous metabolic bariatric surgery is very similar to the early talks that we had on, how to assess a patient presenting with this chronic disease of obesity in the first place. We've just got that extra layer of, within the presenting complaint, could it be related to the surgery that they've had in some way? So more an anatomical or functional aspect, or potentially a nutritional aspect. Is it obesity related, and is it obesity comorbidity related? So has it improved, relapsed, or remitted, or is there a new comorbidity? It is relevant to know what kind of procedure and when it was done. And overall, it's still chronic disease management. So despite having metabolic bariatric surgery, the chronic disease of obesity doesn't go away. And this is sort of, what the audience's core skill set really is. So just in brief, and I am not a bariatric surgeon, so I won't attempt to explain the anatomy in great detail, but we know that metabolic bariatric surgery works as a treatment for obesity. And we know it is not for everyone, and nor does everyone wish to seek this treatment, but it is currently the most or the procedure or the treatment that we have for this condition with the best outcomes. So proven improvements in total body weight reduction, but also quality of life, obesity-related comorbidities, and mortality improvement. Generally, it's considered safe worldwide with a very low mortality rate, particularly for primary bariatric procedures. Historically, the adjustable gastric band, due to its ease of placement, it's very low risk at the time of insertion, and was very popular, particularly sort of 15, 20 years ago. But the later complications have emerged as more of a problem, leading to its decline in popularity. So not frequently done these days, but there are many patients out there who have a lap band in situ. So things like band slippage, band erosion, infection of the band or port, dislodgement of the port site may occur at any point. And then erosions and ulcers around that site. The Roux-en-Y gastric bypasses, second from the right there, was probably the historical gold standard in terms of bariatric surgery. And then the vertical sleeve gastrectomy was initially, I believe, commenced as a way to try and reduce the risk of those patients, or reduce their weight in preparation for a second stage Roux-en-Y. But then when they saw the outcomes from this, it's emerged as a standalone procedure, and worldwide, laparoscopic sleeve gastrectomy is the most common bariatric procedure. There's a whole bunch of other rearrangements of the gut that I won't attempt to explain, nor do I have a great understanding of. One of the more common ones recently is a mini gastric bypass, or one anastomosis gastric bypass. So trying to bridge that outcomes of the more intensive surgery with minimizing the longer term nutritional deficits that go along with more invasive surgery. The Obesity Canada guidelines have some nice sort of introduction about surgical options, and a bit of a comparison of the different weight loss surgeries in terms of average total body weight reduction, sort of in that 20% range for adjustable gastric band, all the way through to up to 40% total body weight loss from duodenal switch. Good remission of comorbidities across the set of bariatric procedures, but increasing with increasing weight reduction, and overall very safe procedures, and a slight increase in serious adverse events as the surgery becomes more technically complicated. And then also with longer term risks, you can see as the surgery gets more technically complicated, there's more sort of issues with nutritional deficiency. So where does Australia sit in terms of what procedure we're doing? Well, in the 9th annual report, and just recently the 10th annual report, very similar numbers, but 80% is laparoscopic sleeve gastrectomy. It's the most common procedure done worldwide, and Australia is no different. As you can also see, the vast majority of these are performed in the private sector with limited public access, sort of guided by individual states and territories and their funding. The average sort of demographic is largely female, in their 4th decade of life, but the men who do come forward are also at a similar age. Generally considered very safe, particularly for primary surgeries. And of the 14% who do, of this registry data cohort who have diabetes, they do tend to have slightly lower, sorry, not 14%, that 29% weight loss at 1 year, but 14%. So diabetics tend to be traditionally more resistant to weight loss strategies or intensive management strategies, but good remission numbers. Realistic weight loss goals are really important, I think, for our patients especially, but also for us as doctors. And seeing someone in your clinic with a BMI of 40, but who has already had significant total weight reduction, can be really challenging to put into context when you can see that they still have obesity-related comorbidities, but equally they may have already done a lot of work to get to where they are and already have had substantial health benefit as well. In terms of the patient goals, you'd hope that a lot of this work has been done in the preparation for and the support around surgery. But even so, we still get lots of people who have a specific goal in mind, and often that's number focused. And if there is inadequate weight reduction for them or weight regain after surgery, that can be really challenging to manage, as also in the mental health space, as Louise beautifully talked about. And obesity is a chronic disease, so it can relapse and progress. Those who have had prior metabolic bariatric surgery will need lifelong follow-up. So it's not a matter of the surgery being done and then off they go into the sunset cured. So this is a graph that I've found really helpful in trying to understand how the patients that I see travel in their post-sleeve gastrectomy at the Obesity Management Service journey. This is a large data set from the Netherlands across a number of different institutions there, but they tried to plot on centile charts, understanding that people do have very varied outcomes, and I think the audience are very familiar with centile charts, say for child growth, and sort of identifying that everyone runs their own course, but as long as they're sort of sitting on their track and sitting within, the major standard or the plus and minus standard deviation from the mean, they're probably doing okay. Probably the main difference between, say, the growth charts and bariatric surgery charts is not everyone starts at the same time point for bariatric surgery. And so you may not follow a curve nicely. You can bounce around within those centiles. But having someone who sits outside 2 standard deviations of the mean, both above in terms of excess weight loss, but also too low, that helps me identify those who may need additional support. As you can see, the majority or peak weight reduction occurs in that first 2 years, with a gradual settling, or what we call a new weight set point. and a little bit of weight regain in the period afterwards. And there's gastrointestinal metabolic adaptation, and perhaps some re-emergence of old habits or reverting to old ways, which may contribute to that. But if you don't see a little bit of weight regain, that might be indicative of a problem such as an atypical eating disorder, for example, or not quite meeting their nutritional requirements. Just for reference, the Australian data does sit pretty well at the 1, 2, and 3 years from the 9th bariatric surgery registry data. And again, sort of similar cohort, perhaps a few less diabetics than there was in the original cohort. Similarly, we see very similar weight trajectory curves for Roux-en-Y gastric bypass. So these were slightly more historical procedures. So there were more of these patients in this data set, but now we're doing more sleeve gastrectomy. Very similar demographics, largely female, 4th decade, BMI at outset in that class 3 range, and about a 5th type 2 diabetes. And again, the Australian registry sort of numbers at 1, 2, and 3 years sitting almost exactly on the 50th centile line. But we don't treat average patients, we treat normal patients, and they will be normally distributed. So if a patient has 25% total body weight reduction from their laparoscopic Roux-en-Y gastric bypass at 1 year, they're still sitting within that, plus or minus 1 standard deviation of the mean, and they're probably doing pretty well. And one of the one of the comments that I heard at a recent conference was that even the worst performing laparoscopic sleeve gastrectomy patient will probably still be doing better than our currently available pharmacotherapy, although this might be changing in the next few years. And weight regain is common. So there should be, and there is expected to be, a little bit of weight regain, so in that 5 to 10% range of total body weight lost, and usually occurs after that 2-year period. Identifying those with inadequate weight loss or early regain and excessive regain, so using those charts is sort of how I try and figure that out, is important. So we know the patients who we have to step in and support more. This may be related to stretch of stomach, that return of some dietary habits, so creep of portion size, grazing, comfort and stress eating, and some of those things that Louise talked about really well. So using alcohol, perhaps self-soothing with other mechanisms, and underlying all of this is our chronic disease that can progress. And just a reminder that it is hard having a sleeve gastrectomy or other malabsorptive procedure. It takes work to continue and to persist with the types of changes that are required for long-term maintenance of weight. So trying to fit your nutritional requirements into that significantly reduced stomach size, managing your fluid in and around that, making sure that you get the higher protein to try and maintain your muscle mass and bone density, which is really important when you're losing a lot of weight. The recommendation for a bariatric specific multivitamin for all metabolic bariatric surgery from laparoscopic sleeve gastrectomy onward. General advice to try and avoid alcohol, but also caffeine and carbonated beverages with the phosphoric acid potentially increasing the risk of ulceration. But many patients also don't tolerate it very well because it occupies more space in the stomach. And this is a psychologically very disruptive process, and it's very demanding. And major changes in body weight can, as Louise talked about beautifully, lead to major changes in a person's life. And long-term follow-up for many reasons, and all of the above reasons, is really important. And dietitian support, really, the dietitians, I think, do most of the heavy lifting in our post-bariatric surgery space. So there are guidelines published in 2020, and this is probably my sort of most important reference document, supplemented by bits and pieces that I've learned along the way from various talks. It's a fairly meaty document, and the Australian Public Bariatric Surgery Framework draws heavily from this. And most public bariatric services, and I presume most private also, will guide their post-operative management on these guidelines. And we do at the OMS too. But slightly more digestible, and I think what I found useful to go to were the Canadian Adult Obesity Clinical Practice Guidelines. So in earlier talks, we referenced some of their guidelines, but they really are quite good, and they have a specific post-bariatric surgery one, which I would recommend. And I haven't been able to go to it in detail in this talk, but it also has a table with clinical features for nutritional deficiencies and treatment regimens for nutritional deficiencies also, which is quite useful. So from those original guidelines published in Surgery for Obesity and Related Diseases, this is the summary table. And it's quite comprehensive, but perhaps not so intuitive, as they don't group like things with like things. But as you can break it up into the early post-operative care, so the top part, and then the lower part being the more follow-up with the different intervals between 1 and up to 12-month follow-ups. And then you choose your surgery along the right-hand side of the page, and you can go down and look at what things are recommended at various time points. But it is a little bit busy, so I've tried to divide things or summarize things into the short term, medium term, so that initial up to 2 years, and then the long term beyond 2 years. But generally speaking, the early post-operative care should be provided by, or is provided by, the surgical team. But you may well have someone turn up who has disengaged with a surgical provider, has moved from somewhere else, or potentially even for whatever reason has sought their bariatric surgery interstate, for example. And so they may turn up in your clinic. And so having a reference document to check as to what is needed in this space is helpful. In the short term, a general post-operative recovery, so surgical complications, wound healing, bowel and fluid, making sure that people are maintaining their fluid requirements and they've got regular bowels are really important. That transition to solid food over the first 4 to 6 weeks. Medication reviews, so similarly to what Louise was talking about, depending on the type of procedure, but monitoring for efficacy, toxicity, controlled release formulations versus immediate release. And then some obesity-related comorbidities can change very rapidly. For instance, diabetes and glucose control. So if they're on insulin, for example, may need very close watching. Checking in that patients tolerating their supplements, particularly the multivitamin, and gentle reminders at each interval. So how are you going with maintenance of your lifestyle habits? You're not smoking, or can I help you with relapse smoking? Avoidance of non-steroidals and aspirin. So long-term and chronic use is particularly high risk. Intermittent 1 or 2 days or the odd ibuprofen for a headache is considered lower risk in terms of ulceration. But the general recommendation is to try and avoid them. Avoidance of pregnancy, particularly in those first 12 to 18 months, and reminders about contraception. Post-operative prophylactic PPI for reflux, particularly for post-sleeve gastrectomy, at least 2 weeks is usually prescribed, and then we review that ongoing. Reminders about alcohol intake. There is a significant change in alcohol metabolism, even with sleeve gastrectomy. And not knowing how alcohol impacts you post-surgery is also important. So noting that it's important to check how you react with it before you drive, and the carbonated drinks for that ulcer risk. Mostly this, as I said, this short-term care, and if there's any concerns about this, you would hope that you'd have an open avenue with the surgical team, and this is generally well provided from that avenue. And then we get into the acute phase, so in that the medium, and then also in the longer term. And this may, depending on where your patient has had surgery, be guided by the surgical team and their multidisciplinary support team. But often, I would say, particularly later on, there's the goal to try and transition patients to their primary care physicians. The medium, that first year, and first 1 to 2 years. So the important things are monitoring a patient's weight trajectory. So while it's not always all about weight, that is one of the simplest measures we have as to how surgery is going. And in relation to their progress to date, so as I alluded to in the graph, someone might lose a lot of weight very early on and then plateau, or someone might just gradually chip away at their weight. Everybody's very different, and it's hard to predict. And that's also important related to the procedure that they had. Particularly for those who may struggle with a particular goal in mind, or wanting to reach a particular weight or BMI. Reframing that sometimes is really helpful. So I've had some wonderful examples that have been brought to me by patients. So one lady in tears because she went on a holiday and she didn't have to ask for the seatbelt extender. So something she never would have really thought of as a goal for bariatric surgery before she undertook it, but was something that she noticed afterwards had made a big impact on her. And another lady who I'll never forget came in and told me how she could now fit in the cupboard playing hide and seek with her grandchildren, and that was just absolutely delightful for her. Comorbidity assessment, so improvement, remission, medication review. Can we deprescribe, or should we be deprescribing things like antihypertensives, or reviewing diabetes medications? Checking in with their emotional health. and screening for psychosocial changes, because bariatric surgery is very disruptive, and so we've seen a number of people undergo major life changes, so job changes, relationship breakdowns or new relationships that can have really big impacts on people's lives in the post-bariatric surgery area, and addiction transference, as Louise has beautifully talked about. Checking in on how they're going with their lifestyle modification and motivation. So there's baseline smoking, alcohol, regular weight-bearing exercise, particularly important for weight maintenance, but also to try and minimize the loss of metabolically active muscle mass, and to improve bone health. How are they going with their eating patterns? So one thing I also learned from my recent conference was not so much saying, how's your diet going? Because that can carry some negative connotations. But how are your eating patterns? Are they regular? Are you meeting your nutritional requirements? Are you tolerating your supplements? And if they're not, looking at alternatives. And again, as I said, the dietitians really do, I think, a lot of the heavy lifting, particularly in the first 2 years in the post-op management space. And so having that dietitian support is invaluable. In terms of the regular pathology test, so it is a little bit individualised based on the surgery type and what issues your patient might have had preoperatively, in particular in terms of nutritional deficiencies, so vitamin D and iron, for example, and then also related to their comorbidities, so if they're diabetic or if they have thyroxine that needs adjustment, as it's a weight-based dose. So usually 3 to 6 monthly for the first year. We do a basic full blood count, electrolytes, B12, folate, vitamin D, at least initially a thiamine for post-sleeve gastrectomy, but much more important for the more malabsorptive procedures and iron studies. There's other risk factor or comorbidity monitoring blood tests like fasting lipids, HbA1c, and the liver function test, of course. And then again, depending on the type of procedure, so particularly for the Roux-en-Y gastric bypass and above, micronutrients, the copper, magnesium, selenium, and zinc, and the fat-soluble vitamins A, E, and K, not so much recommended or required for sleeve gastrectomy, although we do check it at intervals at the Obesity Management Service. Vitamin B6, so can be both deficient, but also toxicity has been something that's come up not too recently, but vitamin B6 can be present in quite high amounts in over-the-counter sort of non-bariatric specific multivitamins, and then was not that well regulated and can be present in a lot of supplements. And we often have a lot of patients come in sort of feeling very healthy and they've lost a lot of weight and they're starting to supplement with sort of over-the-counter or from health food stores, things like protein powders with extra flavors. And sometimes in the fine print, you'll see that there are additives like vitamin B6, and excess can also be a problem. And bone health, and I think the audience is probably much better versed on bone health than I am, but that's a very important part of post-bariatric surgery management. Some of the red flags, particularly within the first year, poor food tolerance in general or intolerance of previously tolerated foods, severe or uncontrolled reflux, vomiting, that's not sort of related to accidentally having larger amounts of food, for example, abdominal pain, excessive diarrhea or steatorrhea, and excessive weight loss. So those people who sit outside that the standard deviations from the mean. And calling on support in that regard. So particularly within that first year, I think discussing with the surgical team or the surgical support team is really helpful. And some of these conditions can be managed by dietetic review. So for example, the vomiting or sometimes the diarrhea, and again, depends on the procedure. And then weight regain, so monitoring for that. For the longer term follow-up, so this may well be where you see patients and they may not have had bariatric surgery under your care, but they've turned up for some very different reason, and that's just listed in their history. So things to check, so weight stability, weight regain. What was your weight nadir? How long did that take? How was the pattern of your weight regain? Was it rapid? Was it gradual? Were there certain triggers? So very similar concepts to obesity history in general. How are they going with their lifestyle measures? So have they relapsed smoking or have they maintained abstinence? Have they recently quit? And maybe that's one of the things that's contributing to their weight regain. What is their alcohol use like? Are they participating in some regular weight-bearing exercise? So again, important for bone health, but also maintenance of long-term weight loss. What's the quality of their eating patterns and the type of diet they're eating, particularly protein? Are they getting enough of that? And how are they tolerating their supplements? Checking in on emotional health. And then once people are stable, generally annual bloods are recommended based on the type of procedure they had. So for the more malabsorptive procedures, still checking in on the micronutrients, particularly if they've lapsed in terms of their supplements. Consider bone mineral density, usually at 2 years, and surveillance endoscopy, particularly if there's the more invasive procedures or severe reflux, or if there was pre-existing reflux that you want to monitor. Just a couple of notes on bone health. So as I suggested, I think the audience is much better versed on this, but some things I found really interesting are the importance of making sure that their calcium supplementation is calcium citrate over calcium carbonate, because that's much better absorbed post-bariatric surgery and also may have a role in reducing the risk of renal stones. Making sure their vitamin D is up to date or in the recommended range. Depending on the age of the patient, some physicians, I guess more from an endocrinology background, so they're more aware of it, but consider baseline parathyroid hormone and may use bone turnover markers. One point that was considered very useful was, instead of a standard 2-site, so hip and spine bone mineral density testing, consider the addition of a 3rd site, so the forearm, which can increase the sensitivity of the test. The regular weight-bearing exercise or anti-gravity exercise can't be underestimated, and the risk tends to be highest in the 5 years post-surgery and highest with the more malabsorptive surgery options. And considering the demographic of patients going through this surgery, so largely women, largely in their 4th decade, that risk for bone deterioration is higher, particularly as we head into the menopause. And when we're looking at treatment, particularly for treatment-resistant nutritional deficiencies or treatment of osteoporosis, I'm trying to avoid the gastrointestinal route, again, particularly for the more malabsorptive procedures. So literally one slide on later complications of metabolic bariatric surgery, because these are hugely varied and challenging, and I don't perhaps feel adequately qualified to talk about these, not being a surgeon. But I put gallstones at the top of the list because I think that's something that I see most commonly. So people having episodes of biliary colic, plus or minus obstruction, rarely pancreatitis. Kidney stones, being aware of that and the increased risk, particularly again in the more malabsorptive procedures, not so much sleeve gastrectomy. And then specific to the procedure, so laparoscopic bands such as more early pouch dilatation and port disconnection, and then later infection, band migration and leakage, and later still esophageal dysmotility. Sleeve gastrectomy, reflux is probably one of the more problematic side effects of that, and with time, potentially the development of strictures and monitoring for the more common nutritional deficiencies. Roux-en-Y gastric bypass, far more invasive in terms of surgery, and so along with that, if there's more staples and more connectors, then there's more places for things potentially to go wrong. Dumping syndrome is far less common with sleeve gastrectomy, but more common in Roux-en-Y, and sort of different etiologies depending on when it occurs in relation to food. Again, nutritional deficiencies, bile acid diarrhea, or even pancreatic insufficiency, and related to the sort of physical surgery, small bowel obstructions and internal hernias. And then, of course, weight regain. So I just had a couple of cases that I thought I'd race through, if that's all right, just to describe some of the situations in which we've had patients who've had post-bariatric surgery. So this is a lady I actually saw in the respiratory and sleep clinic after she was hospitalised for pneumonia and exacerbation of her asthma. She was very keen to re-engage with her weight management, had not long ago engaged with what sounded like an excellent GP, but wanted to talk about her weight management. And when she found someone vaguely interested in that, which I confess to, we had a longer consultation than was originally planned. So at the time of review, she had class 1 obesity with a BMI of 30.8, and she'd had a sleeve gastrectomy 10 years ago. She described a progressive gradual weight regain of 12 kilograms from a nadir of 70 kilograms. So she'd regained 50% of her total body weight. And generally more than 25%, it varies a bit in the literature, but if you've gained more than 15 or more than 25% of your total body weight, then you're falling into that, relapsed obesity category. Reflux asthma, for which she took PRN short-acting bronchodilator only, a history of depression and anxiety, and exacerbated by some workplace issues. She had chronic back pain and a history of iron deficiency. Her medications included 2 antidepressants, her intermittent salbutamol, treatment for her reflux, as required paracetamol for her back pain, and she took a regular iron supplement. And also noted during that admission was that she had a wedge compression in her wedge compression fracture of the thoracic vertebra T12. So our goals, and I guess I always think of my goals and the patient's goals, and the patient's goals, of course, paramount, but try and incorporate my goals into that as well. But her primary concern at the time that I saw her was that she'd regained weight and had noticed that her health had declined post-metabolic bariatric surgery. My goals included trying to optimize her asthma because it clearly wasn't well controlled at the time I saw her. I thought about the duration since the surgery and wondered if she'd had post-operative screening for nutritional deficiencies, and her history of iron deficiency was important there. I was concerned about her bone health, and we'd documented that spinal fracture. I was thinking about elevators, things that might drive elevated body weight, and thinking about sleep, and checking in with her mood given her history of depression and anxiety. So we sort of go to the guidelines and we have a look and we try and group the like things together. But essentially her basic bloods were all quite good. Her iron stores have been maintained on her regular supplement, and her vitamin D was replete. So also important from her asthma exacerbation risk point of view. When we did a brief dietary history, we identified that checking in with a dietitian and revising some of those post-bariatric strategies was important. And we also identified that her alcohol use, so 2 to 3 standard drinks most days and sometimes increased on the weekend. And she self-identified that she was using that to try and offset the stress from her work situation. We re-established a regular bariatric-specific multivitamin with additional calcium supplementation because her diet was felt to be a bit deficient in calcium. We re-established regular preventer therapy, including an inhaled corticosteroids as per the National Asthma Handbook guidelines. So either baseline preventer inhaled corticosteroid or the combination like the Symbicort MART therapy, PRN, or regularly. And then she had a bone mineral density, which confirmed osteopenia. So just in very brief, over the course of the year, she engaged with her GP, who really was excellent, re-engaged with a psychologist. She quit alcohol. She re-established her regular eating pattern, and she significantly improved her asthma control on her new regimen. She very pleasingly re-engaged in a regular physical activity, and I won't mention it because it might be identifying, but it was weight bearing, and I was very happy with that. And at review at 1 year, she'd had a 9 kilogram or 10.6 total body weight reduction, and her obesity was in remission. That was really nice. And then a second case who was referred to the OMS from the endocrinology clinic. Her primary concern when she came to us was concern about obesity relapse post-metabolic bariatric surgery. Her current weight was 119.2 kilograms and a BMI in the class 3 range. And she unfortunately had regained all of the weight that she had lost with her Roux-en-Y gastric bypass in 2016. She had iron deficiency attributed to her gastric bypass and wasn't on a supplement because she's told she wouldn't absorb it. She had osteopenia secondary to malabsorption and treatment-resistant vitamin D deficiency with prior foot and vertebral compression fractures, and that's why she was known to the endocrinology clinic. She had knee osteoarthritis, awaiting a knee replacement, a previous cholecystectomy, and a history of depression. She was taking a bariatric-specific multivitamin and also undergoing approximately annual iron infusions. She had a very impressive vitamin D supplementation regimen, and I was very pleased that endocrinology were helping to manage that. She was on fluoxetine for maintenance of her antidepressant therapy. She had not long ago recommenced melatonin for sleep disturbance. And as part of her bone health management, she was due to start hormone replacement therapy. So further history, following her Roux-en-Y gastric bypass, she had reached weight nadir 2 years after her surgery, and then described a gradual increase in weight, regain of nearly 40 kilograms since then. Her obesity had onset in young adulthood, and previously to the surgery, she'd had success with very high intensity exercise interventions, but they just weren't sustainable in the long term, sort of exercising twice a day, and they were inevitably followed by weight regain. We reviewed her current eating patterns, and we identified that it was low in protein, and there was frequent skipping of meals with sort of stacking of food towards the end of the day, and low in calcium intake. Her physical activity had been limited by knee pain, and she also described progressive breathlessness that she'd largely attributed to the weight regain over the last few years. She was a very distant ex-smoker with 5 pack years and no diagnosed lung disease. She'd had a previous diagnosis of sleep apnea, but stopped using her CPAP at her weight nadir more than 10 years ago. But she described the re-emergence of disrupted sleep, sleep maintenance, insomnia, and her Epworth was variable, but at one point up to 14. Her psychosocial history, she was working full time, she had a very supportive family, and she didn't identify changes in her mood as being a major issue. Her DAS21 screens were also within normal limits. So the patient's primary concerns, I was interested in her breathlessness, limiting her activity, her generally reduced energy levels, and the relapsed obesity. And because she was seeing us at the OMS, we could focus on these things. So obesity assessment as that had relapsed, and then comorbidity assessment in that context, and including the nutritional deficiencies that we might see after Roux-en-Y gastric bypass. Her bone health, thankfully, complex and was already being managed very well by endocrinology. And I also wondered about potential drivers of elevated body weight. So sleep, for example, and reviewing her pharmacotherapy, no obvious weight gain promoting medications. Again, going back to our slightly disorganized table, that most of the information is there. We did baseline and screening blood, sort of combining obesity management and post-bariatric surgery management. Her iron was low, and it had been some time since her last iron infusion and may in part have explained her breathlessness and low energy levels. Her vitamin D was also low despite the expert guidance of the endocrinology clinic, but her B1, so thiamine, fat-soluble vitamins and trace elements were all within normal limits, and I think reflected her maintenance of her multivitamin. Her sleep study showed residual moderate obstructive sleep apnea and slightly reduced saturations at baseline. Her bicarbonate in serum electrolytes was slightly elevated, was still within normal range, but above the 27 cutoff that we talked about. So I wondered about hypoventilation. Her lung function was normal, and she had an ABG that excluded hyperventilation, but just confirmed that mild hypoxemia with a reduced PO2. And so for completeness, we did a VQ scan, and surprise, surprise, there was a PE of indeterminate time frame. So we brought her back, we reviewed her history. There were no clear provoking or inciting factors and no clear onset date to the shortness of breath, but she did have the risk factor of increased body weight. So we commenced her on anticoagulation, and after discussion with her, we called it an unprovoked and given the unclear time frame, an unprovoked PE, and we decided to continue anticoagulation. And a 6-month VQ showed clearance of the defect. She enrolled in the Obesity Management Service sort of refresher group education, and her feedback was that, yes, she'd heard some of this before, but it was nice to hear it again. She had one-on-one dietitian reviews, EP reviews, and she attended the informed eating group, so looking at non-hungry eating. She re-established CPAP, and she did find that that led to better sleep quality, and we excluded the obesity hyperventilation. Her iron infusion was brought forward, her celiac serology was negative, and she had ongoing endocrinology follow-up from a vitamin D and bone health point of view. We added in anti-obesity pharmacotherapy to support her with weight reduction. So semaglutide initially as a private prescription. And she had varied successes, like most of our patients, with obtaining it or getting a supply. And then at review in April, phentermine topiramate was commenced, and she was determined a treatment responder. And at last review, which is not long ago, she'd had a total of 23.7 kilograms total body weight loss, and about 20%. So she was really happy with how she'd gone. So I guess just in summary, each patient and their problem will be different, and it's a really big topic, and it's hard to sort of give a one-size-fits-all approach. But just adding that prior context of metabolic bariatric surgery and thinking about the potential complications of that can occur downstream is helpful. It's chronic disease management, and this is what you're really good at. So I think you'll be okay. And resources in terms of guidelines and reaching out to other care providers. So I think that's one thing we've been trying to do more at the Obesity Management Service is make bridges to other services. So with Louise being on the mental health sort of physical health steering committee, for example, and having roads open to other departments like the Department of Respiratory and Sleep Medicine, and maybe trying to engage our surgeons as well, which would be really interesting. Of course, there's lots of things that I haven't been able to address. So in particular, pharmacotherapy and general principles post-operatively, back to first principles, pharmacokinetics, what medications might be impacted by significant changes in weight. Anti-obesity pharmacotherapy for those patients experiencing weight regain, and that's a big topic on its own. And there's not a lot of evidence in this space, but it's a fairly sort of established, I think, clinical practice in the long run. Nutrition specifics post-metabolic bariatric surgery, so how much people need, and I do rely heavily, as I said, on our dietitians who do most of the heavy lifting, I think, in the post-bariatric surgery space. Haven't been able to talk about fertility and bariatric surgery, but there are references or there are sections in the guidelines. Specific management of nutritional deficiencies and those potential complications in detail. And then, of course, as Louise has beautifully spoken about, the mental health aspects, which I think are very important and almost one of the most important things for our patients. And some references with the two in bold there being the sort of the more bulky guidelines, and then I think the nicer and easier to read Canadian Adult Obesity Clinical Practice Guidelines. Finished.
Thank you very much, Deborah. That was great. So I think we can remember that from Louise, it's the Maudsley reference, and from Deborah, it's the Canadian Adult Obesity Guidelines, if they're the references we want to take away from tonight. We have a question, and the question is, could you comment on gastric balloon versus bariatric surgery?
Yep. So I'll preface it by saying I am not a proceduralist and I don't do these procedures. So my understanding of it is purely from a physician perspective. So there are a number of endoscopic, I guess, tools available out there with varied access, I guess, at different places. We have very limited public access to the endoscopic arena in public medicine. So my experience one-on-one with them is limited. Probably the Allurium balloon is the one that I've heard most about most recently, and it's licensed in Australia only for a BMI of up to 40, so not beyond 40. I think overseas it has been used beyond that. But from my understanding, it's a small capsule that is swallowed. It's attached to a radiolucent tube. X-ray placement is confirmed. And then the tube is disconnected from the capsule, which then inflates and contains fluid. From what I've heard, there's an almost immediate sense of fullness, satiety, and these patients do require quite a lot of support in the 12 weeks that the balloon exists in their stomach. Then it typically deflates and is passed in the stool. So some of the clinical situations, I think, where this has been talked about being useful are for those who are unsure about whether or not they want to proceed with bariatric surgery and want something reversible to try. For those who might have a specific goal in mind where they want to lose weight, and the weight sort of reduction over that 12 weeks, I think is very similar to a supported very low energy diet intensive phase, around that 10, 12, 15% total body weight reduction. Again, depends on the patient. I guess that's probably the major difference, while other surgeries are not so much the laparoscopic sleeve gastrectomy, but they have, like the band, for example, is reversible, and the Roux-en-Y gastric bypass technically is reversible. It's not something anyone would undertake without, strong justification. Does that answer the question a little bit? Sorry, I can't hear you, Leonie. I think you're mute.
Yeah, that's great. Thanks, Deborah. I think I've seen there's one private doctor in Canberra who's offering the balloon, the gastric balloon. So, but I haven't had anybody who's done it. So, yeah, but that sounds interesting as a kind of a foot in the water, but it's an expensive foot in the water. I think you mentioned this in the previous webinars, so apologies if you're repeating yourself, but where do people buy the bariatric specific multivitamins and how much do they cost?
So exactly how much they cost, I'm not sure. I can do a quick Google. But say, for instance, the BN multivitamin, I think it's about $100 for 100 tablets. Correct me if I'm wrong, Carol. Most of our patients honestly do order them online because they can be a bit patchy in their availability from your general pharmacist, and I'm not aware of any supermarkets that stock them. The Terry White Pharmacy in the hospital, I believe, after Carol contacted them, agreed to have it in stock, so they should have it available. But I don't know if Carol wants to step in if you know any more, but depending on what they need. We've had a number of patients turn up with different concocted versions of over-the-counter or adding up lots of individual supplements. And each time our dietitians check, ultimately it does work out to be cheaper to take the bariatric specific one.
So I've just had a look on the internet. So to get BM multi, you're looking at $35.95 for a bottle of 60 tablets, and the usual dose is 1 twice a day. And they come in 2 different formulations. So generally speaking, early in the post-operative course, what's usually being prescribed is the chewable multivitamins. And then, but I get that the taste is not great. So many patients eventually transition to the capsules. But the important thing to know is the capsules does not contain the calcium, which is in the chewable vitamins. So you will have to have additional calcium supplements.
Thank you for that.
Thanks, Carol.
Thanks. And we've just got another comment from one of the attendees that they have more than 50 Allurian balloons at Capital Metabolic Clinic. So if you need more information about them, reach out from Emily, the dietitian. And also wanted to say, great talk so far, Deb and Louise, and I'd second that. I've found all the obesity management webinars so interesting and so useful, and tonight's no exception. And the YouTube channels, we've only just made them public, and the last one, so since the last one, we've just made them public so anybody can watch them, and we're getting up to about 9,000 views on webinar 4. So obviously there's an appreciative audience out there. So thank you very much. Any more questions from anyone? Because we're about to wrap it up. I just thought I'd ask quickly about the semaglutide post-bariatric surgery, which you mentioned briefly. It's not routinely used, but just used when there's weight regain. Is that correct?
Yeah, so very limited evidence, of course, in the post. So often these patients who've had prior bariatric surgery are excluded from the clinical trials. In this instance, it is off-label use, but with Wegovy becoming available sometime, anytime nearby, and being relisted on the PBS or re-put forward to be listed on the PBS in November of this year, we may well have a real option in this space coming soon. I guess all our fingers and toes are crossed. I do use anti-obesity pharmacotherapy, both off-label and on-label. So if a patient can afford and wants to try liraglutide or Saxenda, then we do that because it's slightly more available still than the semaglutide. But knowing that semaglutide head-to-head really does beat it in terms of weight reduction is often where I would like to go. Again, accessibility, affordability are probably one of my biggest drivers. And I guess the other thing that's really important is their prior history. So have we tried an anti-obesity medication in the past, and do they have one that works for them? And often if patients are self-funding anti-obesity pharmacotherapy, like for instance, Ventolin, topiramate, and then they go through public funded surgery, we'll try and use that as a weight set point lowering device and save them the money from the anti-obesity pharmacotherapy and use that again later if we need it. That's sort of the approach that I've been taking. I don't know if the others have anything different.
I think I agree with that approach. I guess the other times where you might consider sort of using it would be if you're having inadequate weight loss early on. But I think it's important to remember that pharmacotherapy is no replacement for trying to get the lifestyle right. So that means adequate nutrition, physical activity, and having the right sort of mindset, and those are just as important. I mean, it's easy to write a prescription, but if you don't fix the underlying issues, then you're probably not likely to get those good results.
Yeah.
Thanks. We've got one more question and then we better wrap it up because we're getting close to 8 o'clock. So the question was, do any of these procedures reduce absorption of oral contraceptives, assuming patient is BMI under 35?
Yes, a great question, and that's, you know, the fertility and things is one of the things we didn't get to talk about, but there is reference to that in the Canadian clinical practice guideline, but particularly with the malabsorptive, so Roux-en-Y and gastric bypasses, yes, technically the oral contraceptives cannot be absorbed as well, and so pregnancy is potentially a risk, and so the recommendation is to try and avoid the oral contraceptive route and go with a depot or other method of contraception. Yeah. There's some studies looking at sort of pregnancy in that first year associated with increased pregnancy losses compared to those who delay a conception until after the first year. You also, if you fall pregnant in that time, you lose your metabolic window for weight reduction because you've really got to focus on growing a healthy fetus as much as you can. There is some really interesting stuff on babies born to mothers before bariatric surgery and then after bariatric surgery, and things like methylation of type 2 diabetes genes, and, you know, potential intergenerational impacts on that child's later risk of things like diabetes and metabolic disease. Generally improved pregnancy outcomes, like things like preeclampsia and gestational diabetes and less macrosomia, but maybe a slightly higher proportion of restricted growth babies post-bariatric surgery.
That's very interesting. Yeah.
Mm.
Thank you. Okay, so thank you very much to our panel and to our speakers. And that's the final webinar. I think we've kind of exhausted our presenters, and they've been so nice and so generous with their time and their knowledge. So thank you very much to them. CHN will send out an evaluation survey and attendance certificate so that you can self-report your 90 minutes or 1.5 hours of educational activities on your CPD home. And we'll put a recording of tonight's webinar up on our YouTube page in the next month or so. So thank you very much, everyone, and good night.